Good evening. A very warm welcome on behalf of DocTutorials. Welcome to this very interesting session on So You Want to Become a Surgeon. The big step in your professional career is to decide to become a doctor. The next logical step in professional advancement is to choose a career path that will last a lifetime. And so this session aims to focus upon inspiring and enthusing those of you who wish to take up surgery as a career. And nothing gives me more pleasure than to introduce my dear friend, Dr. MBV Prasad, who will be speaking and addressing various issues that will touch upon introduction to surgery, the history of surgery, how to choose various subspecialties in surgery, what makes a good surgeon, and how to have a work-life balance. Dr. MBV Prasad graduated from Guntur Medical College with multiple gold medals and then completed his post-graduation MS in general surgery at PGI Chandigarh. Then went on to pursue higher surgical training and subspecialty training in GI surgery in the United Kingdom after having passed his FRCS. He then relocated to India, and over the past 15 years, he has been working as a consultant surgeon with special interest in GI and laparoscopic surgery at KIMS hospitals in Secunderabad. He has been the head of the Department of Surgery and the lead trainer for DNB trainees in general surgery here. He, in addition to several other accomplishments, in addition to publishing and lecturing and giving orations, he has a keen interest in training and with specific interest on hands-on, imparting hands-on surgical courses, the basic surgical skills courses, the basic surgical skills courses for laparoscopic surgery and anastomosis skills courses. So here is Dr. MBV Prasad, who also has other interests like reading, Advaita Vedanta, and photography as his hobbies. So I request Dr. MBV Prasad to take over from here and deliver this presentation. Thank you.
Thank you, Dr. Raghu, for the kind introduction. Just start my share. Okay, are my slides visible?
Yes, please go ahead.
Yeah, thank you. Now, good afternoon, everyone. Just sit back and relax. This is not going to be a very serious session as it is. This is just to give you an introduction of what surgery is and what your options are after doing general surgery, post-radiation, and other things. So first of all, the meaning of surgery. It is treatment of injuries or diseases in people or animals by cutting open the body and removing or repairing the damaged part. This is from Cambridge Dictionary. And the word surgery is derived from the Greek word kairos, meaning hand, and ergon, meaning work. So essentially, surgery is hand work. This is from one of my teachers. He used to say, surgery is very simple. All that you have to do is cut along the dotted line and suture it back. But the important point is to know where the dotted line is. Why surgeons are different? I mean, surgeons, if you see in hospitals, they all have a little bit of a different persona around them. Because as surgeons, we inflict injury deliberately on the patients in the hope of making them better. Ours is a all or none phenomena. It is not like physicians where we can try one medicine after the other or one test after the other. So when we do surgery, you are committing yourself and the patient to a particular procedure. And in surgery, there is what we call a window of opportunity. If you don't act decisively in that window of opportunity, there is no point doing the surgery afterwards. Say, for example, in cancer patients, or more so in patients after accidents, trauma patients, patients who are coming with blunt abdominal trauma or blunt chest trauma. If we don't act decisively in time, the opportunity is lost. And that is why we have to be on tenterhooks all the time. And the surgeons need an extensive knowledge of human body compared to other specialties except for radiology. And patient's life is in our hands. Literally, if you happen to be a cardiac surgeon or a neurosurgeon, during parts of the surgery, the patient's life is literally in your hands. So this is all what makes us stand apart from other specialties in medicine. Now, coming to the origin of surgery, our ancestors have had attempts at curing the patients as far back as 10,000 BC. The photograph is what is called a trepanation from Egypt, and that is to drive away the evil spirits from the brain. People those days, they used to think that the mad people, they are harboring evil spirits or bad spirits in the brain, and this is a way of letting the evil spirit out. One way or the other, the patient is cured. And again, there is description of circumcision in Egyptian papyri dating back to 24,000 and 3,000 BC. And the modern surgery in Europe is for cutting off bladder stones in as far back as 200 BC. Coming to the, just as an anecdote, if the physician has healed a man's eye, this is the remuneration. So 10 shekels of silver equals to something like 40,000 rupees in present day. Now look at the punishment. So even our forefathers had to endure the wraths of complications. So you have to be very careful in not giving complications to the patient. I mean, it's not that we would do it deliberately, but one of the prime things in surgery, like in other specialties of medicine, is what we call primum non nocere. First, do no harm. You have to be careful that you do no harm to the patient. Now, coming to the history of modern surgery, it goes back to 15th century. You all know Leonardo da Vinci of the Mona Lisa fame. He's not just a painter, he's a multifaceted person. He has done extensive anatomical dissections and has good knowledge of human anatomy. And Andreas Vesalius is the person you might have seen in your anatomy books, who has written the first textbook of anatomy. And these are the people who paved way for modern surgery. And this is Ambrose Pare, the French surgeon, who famously said, "I dressed your wound, God healed you." That means to say that what we do is simply the technical job, but the patient's body must have the capacity to heal. And this is the father of surgery in England, John Hunter. So he is considered as the father of surgery because he has paved way for the scientific surgery in the 18th century. Now, William Morton is the person who discovered anesthesia, and Lord Joseph Lister is the behind the antisepsis. These two are very key for modern surgery. But for the anesthesia and the antisepsis, we would not be doing all the surgeries that we are presently doing. Christian Bernard, you might have heard, he's the a person who's done heart transplant for the first time, and Eric Muhe is the one who has done laparoscopic cholecystectomy for the first time. So the reason I keep telling my residents about history of surgery is that if you go through the history of surgery, it depicts what problems our forefathers have gone through and how innovative they were and the troubles that they had to go through. there was the picture shows a below knee amputation, and the description of it is that it was done in about 30 seconds, because those days there was no anesthesia and people used to bind the patient forcibly, and the surgeon has to be as deft and dexterous as possible. Nowadays, thanks to the anesthesia and the instrumentation and electrosurgical equipment, we have the luxury of time. We can go very meticulously and take our time and do a surgery. Now, these are the instruments that our forefathers used. This is the laparoscopic equipment that we are using presently. And this is the robotic surgery. And that is the nano robots. That is the future. In future, these will replace many of the surgeries. Those of you who are familiar with Sherlock Holmes will recognize that statement. So the relevance of this is that I put this here to emphasize the relevance of the art of deduction. Sherlock Holmes is a detective, fictional character. So he used to deduce the crime performed based on the minute clues that are available on the crime scene. Likewise, you must have your sense organs open. Our ancestors, forefathers used to use the tongue also for diagnosis. Nowadays, we don't use them, but eyes, ears, and nose. Keep them open and you will get a lot of cues from the patients, which will lead to a proper clinical diagnosis. And for a surgeon, you need manual dexterity and physical skills and knowledge, specialist knowledge for accurate diagnosis, extensive experience of perioperative and postoperative care, and general knowledge. You have to be innovative. Sometimes you have to think out of the box in difficult situations, and you have to adapt to new situations. And these are most important: hard work, perseverance, humbleness. This is a sentence from Bailey and Love, you might have seen. Faced by a patient who has lost the power to heal, the most famous surgeons are reduced to impotence. This again goes to emphasize what Ambrose Payer said. You should know your limitations, both personal and professional, and seek help when necessary. And you should have empathy, communication skills, leadership skills, presentations, publications, learning, and teaching. And again, there is a famous saying that publish or perish. If you don't publish, you get behind in the race. And other thing these days is the knowledge is exploding exponentially every year. So you have to learn, unlearn, and relearn things. So all these things may sound a little bit daunting for you, but I'll put what are the most important things that are necessary. These three are the most important. Attentiveness, like I said, keep your sense organs open, be attentive. Hard work and perseverance. These are the most important to be a surgeon. So you should have the attitude of, I want to do it, I can do it, I will do it. And impossible is not an option. So always try to make things possible. Now, for you to do all those things, you must have coping abilities. It is not that you burn yourself out by doing hard work. You should have the emotional resilience and ability to support yourself and your team in sometimes difficult situations. So you should have some stress busters. You should have a me time. Every day you should have some time allocated for yourself to de-stress yourself and pursue some hobbies, do regular exercise, some meditation, some relaxation, whatever. If you have want to play any games or something or the other, just it's depending on your own personality. Spirituality is perhaps too early for you, but that is something that will help you greatly in coping. Never rely on intoxicants, alcohol, smoking, these sort of things for stress relaxation. Now, coming to the prospects for a surgeon, this is what most of you will be interested in. Once you do your MS or DNB in surgery, what next? You can continue to be a general surgeon, or you can become a neurosurgeon. There are a variety of options these days. You can become a head and neck surgeon. You can become a thoracic surgeon, cardiac surgeon. Previously, these three used to be one specialty, called as CTVS, cardiothoracic and vascular surgery. But nowadays, they have branched out into three different specialties. Can be a plastic surgeon, can be a breast surgeon, can be a urologist, surgical oncologist, can be a GI surgeon, hepatobiliary surgeon. Again, previously, it all used to be a surgical gastroenterologist. Now we are branching out into upper GI, lower GI, and hepatobiliary pancreatic surgeon. A transplant surgeon can be a liver transplant or a pancreatic transplant, or a more commonly the kidney transplant, which is a subspecialty of urology, or even lung transplant. You can be an endocrine surgeon, podiatric surgeon, or hernia surgeon. These are the various options that are available for you after completing the post-radiation. And again, these specialties also have, in addition, the minimal access surgery option, which can be either laparoscopic, thoracoscopic, or the budding specialty of robotic surgery. Now, most of the trainees, when they come to trainee these days, what I have noticed is they are not interested in small surgeries. They want to do big surgeries. So don't be in a hurry. You start small and make yourself big slowly. So the saying is, be a good assistant, because for you to be a good assistant, you should know what surgery is being done, what the steps of the surgery, and anticipate what the next movement is, what the surgeon is going to do next. Only then can you be a good assistant. So if you have all these attributes, by default, the next logical step is for you to become a good surgeon. And again, this is a sort of a general philosophy sort of thing. You have to be fair and honest in all your dealings. This is a quote from Professor Harold Ellis. Sometimes we have difficulty in deciding what is best for the patient. These days, we have a variety of options. Just like I mentioned, open surgery, laparoscopic surgery, robotic surgery. So, and when it comes to cancer, you have non-surgical methods like chemotherapy, radiotherapy. So different options. So in such a dilemma, one of the easiest things, rule of thumb for you, is to put yourself in the patient's shoes and advise the treatment you yourself would have in that situation. You have to be fair with hospital management, colleagues, staff, family, friends, and above all, you have to be fair with yourself. So you have to strike a balance. As mentioned earlier, you have to be hardworking, but at the same time, you have to allocate some time for yourself to de-stress yourself. Like that, you have to have work-life balance. And this is a surgeon, you will come to know once you start your surgical career that there is something called a WHO surgical safety checklist. So this is something that is followed before operating on any patient, that we have got everything in place. And this is the gentleman who is an American surgeon of Indian origin. And it gives a good account of the surgery and its complications. Now, for surgery, for that matter, whatever you do, try to pursue excellence. So this is a quote from Martin Luther King. So even if you happen to be a street sweeper, do the best that you can do. Okay, you should sweep streets so well that all the hosts of heaven and earth will pause to say, here lived a great street sweeper who did his job well. Meraki, this is a Japanese quotation, which means, again, the same thing, to do something with soul, creativity, or love, to put something of yourself in your work. And when you are pursuing surgery, this is something that you have to do. And for you to do all this sort of rigorous surgical training, you have to create healthy habits and try to make excellence a habit. Excellence will get you recognition. Don't run after money and easy money and quick recognition. So if you persevere and make your work should speak for itself. If you do that, money will automatically follow. And this is my concluding slide. This is Robert Hutchinson, the same. I don't think people are reading the Hutchinson's clinical methods these days, but when we were students, This is a standard clinical methods textbook. He's a physician. So this is the quotation from him. The big prizes in our profession are only for a few, and they do not always bring much happiness when gained. If you have earned enough for your needs and been able to put a little aside for your old age, and at the same time, you have won the esteem of your colleagues and the affection of your patients, you have done well enough. And that measure of success is within the reach of most of you. So what it means to say is essentially, so by being a good surgeon, you can have a good life, good earning, and work satisfaction and social esteem. So don't run after, I want to be the best and I want to do the best. Yes, that should be the attitude. But again, you have to balance. You should not cut corners and do unscrupulous practices just to get to the top of the ladder. So you have to work your way upwards and do the best that you can. And most people can succeed and lead a very happy life and as a surgeon. So I wish you all the very best, and we will take any questions that you might have. I will leave you with that slide.
Thank you, Dr. Prasad. I think you can stop sharing. So thank you. That was a very informative presentation that has touched upon various aspects of what it takes to be a good surgeon, a humane surgeon, a grounded surgeon. One question, can you please guide how to stay updated with current surgical procedures?
Yes, we have various continuing medical education programs, and we have various surgical bodies. Once you get to join a surgical training program, one is, first of all, you have a basic surgical training. That is as you know, the post-graduation is 3 years course, and during that course, you will get to know from bedside teaching and seminars and all such things. And in addition to that, you attend conferences and you have various journals. So your mentors will guide you through these things. And after you have done your post-graduation, again, as I mentioned, you have to do the CMEs and attend the workshops and conferences that happen all the time around the year. At any given time, every month, there are 2 or 3 conferences or workshops that are happening.
Is it possible to be an MRCS and FRCS along with being a surgeon in India? So the answer is having organized the MRCS intercollegiate final MRCS courses for more than 10 years and having organized the intercollegiate final MRCS examinations at KIMS hospitals since the year 2008 on behalf of the Royal College of Surgeons of Edinburgh and Royal College of Surgeons of England, I can say that yes, you can do your exams here. It's not just necessarily Hyderabad. There are several centers and the colleges are now conducting their final intercollegiate MRCS examinations in India. With regards to FRCS, there is this intercollegiate FRCS, which is not registrable by the GMC, but it is called FRCS brackets INT, and that is taken for overseas trainees. So to obtain FRCS in the UK, you have to be in the training system in the UK, having completed a certain amount of higher specialist training, after which you would be eligible to obtain the FRCS in the UK. But as far as FRCS International is concerned, it can be taken by any trainee who has completed his basic surgical training. And it is not necessary that you should have an MRCS before you take FRCS International, although it is preferable because you will know how the exam system rolls out. So the information about the MRCS and the FRCS International will be available in the Royal College websites. So the other question is, I want to pursue surgery, but I'm too afraid after hearing many stories of it being too hectic. Prasad?
Not quite if you organize yourself. And again, it is how keen you are. During the first 3 years, yes, you have to put your heart and soul into it. And afterwards, it is your choice how much time you want to spend. And as mentioned in the work-life balance, how much you allocate. I mean, you can just work the elective work. You can be a purely elective surgery and you don't do any sort of emergencies, and you do clinical work and clinics and the operating sessions. And it is your choice. But again, you should not crib that I'm not getting as much money as somebody else. So it is not that surgery, yes, it is rigorous. But at the same time, if you have the will, you will find the time and you can do it. There is one more, Dr. Raghu. I am inclined towards pursuing surgical career in reconstructive surgery. Yes, you can certainly do, but first of all, you have to do general surgery, then plastic surgery. Again, part of the plastic surgery is reconstructive surgery. Again, you can have subspecialty interest in reconstructive surgery, as which part of the body you want to do reconstructive surgery. So it is all a sort of a one step after the other. The first step is to take the dive into the surgical training program.
Okay. Can you guide with best surgical super specialty? I don't think one can guide as to the best surgical super specialty. I think you have to have an interest in pursuing a certain subspecialty. And if you have that interest, because it's going to be for lifelong, and I think there's nothing called best. Whatever you choose, you can make it the best. What should be the highest in super specialty institutes, academics or hands-on?
I mean, just continuing for the previous question, I would say it is your passion. I mean, once you join surgery, during your teaching program, you will rotate through various specialties, and whichever one you like. Again, like I mentioned, don't look for the money. So see what interests you and what passion you have. And based on that, you choose your specialty. And coming to the present question, academics or hands-on? If you can get both, that is better. But again, with the NEET scoring system and the way the things are organized, sometimes you may not have a choice. If you have a choice, probably I would stick to the academics, because when during your training program, if you have good foundation with the discipline, protocols, and how to do it, then afterwards, the actual surgical skills can be easily honed. So if you have a good hand-eye coordination, good knowledge of anatomy, again, just like as mentioned at the beginning of the talk, the surgery is very simple. You just have to cut along the dotted line and suture it back together. So another one of my mentors used to say, surgery is nothing but a good knowledge of anatomy, pathology, and common sense. So all that you need to know is the body anatomy, where you have to cut and how to patch it together. So that after doing 2, 3, 4 surgeries, watching and doing, you tend to get that more easily. Whereas the academic environment that you get in an academic institute, the first 3 years of your training, that you will not get elsewhere. So if you have to choose between academics and hands-on, between the two, I would go for academics.
Would you advise to go for specialty training in the UK, considering the sheer length of the course in the UK?
You take that question, Raghu.
So basically, the question is, would you advise to go straight away to the UK to pursue specialty training instead of doing basic surgical training in India? So my advice is to complete your basic surgical training in India, because you must have a structured training and a degree, from India to fall back upon. Because after going to the UK, there is no guarantee that you will get one can get on to a structured training program that leads to Certificate of Completion of Specialist Training, which is called CCST, which gives eligibility for somebody to practice in the UK. So not everybody is able to get onto that consultant ladder. So it's always good to complete basic surgical training here before pursuing higher specialist training in the UK. So the other question is to shed some light on how one can improve portfolio and CV if one has to get shortlisted for core surgical training in the UK, as very few Indian doctors are given surgery.
Well, I mean, you just have to spruce up your CV by having some publications, and essentially your CV should stand out compared to the local candidates. So you are competing against the local crowd. So you are a non-local there. So for you to get there, your CV should stand out. Like, so let us say, if you have any academic distinctions during your medical school, or if you have done post-graduation from a premier institute, or you have done some publications during the course, all these things will set you apart. So, Raghu, anything else?
I think that's a valid answer. And
there is one thing, how do you rate bariatric surgery? Yes, I forgot that in the list of surgeries that I mentioned. That is yet another specialty, a subspecialty of GI surgery. Now, again, it is a highly specialized branch, and it has its takers, and there is enough volume of work. But if you have passion for that specialty, you can go for it. It is like, it is not that one specialty is superior than the other. As far as the patient is concerned, it is patient's life. Whether you are doing as a general surgeon, if you are doing a perforated duodenal ulcer, or doing a very complex liver transplant surgery, or lung transplant surgery, or bariatric surgery, whatever it is doing, it is one patient's life. So the dealing with perforated duodenal ulcer in the middle of the night may not look very glamorous, but you are saving one life. At the end of the day, it is a life that you are saving. So don't look at the specialties with their glamour and panache. Just stick to what suits you, your temperament, and your skills and your knowledge, and how much time you can put into for a transplant surgeon's life from the outside looks very glamorous. But if you look at the sort of the number of hours they put, and if whenever there is an organ available anywhere in the country, they have to take a helicopter or a flight and go there, retrieve the organ and come back. In the initial days, it looks very glamorous. But if you have to make that day in and day out for 365 days a year for the rest of your life, it becomes very tedious, and you may not have much family life. So all these are the sort of things that you have to keep in mind. Some people have the passion for it and they go for it. So it is up to you. It is not for someone else to say that this is a good branch and this is not a good branch. So every branch is good. It is up to you and your goals and passion that should guide you.
Throw some light on the DNB course in surgery.
We don't have many such courses. So we used to have one in neurosurgery and one in CT surgery. The 6 years is for the first year, 3 years used to be general surgery, and the next 3 years used to be the specialty training, or 2 + 4. So basically, at the end of the 6 years, you will get an integrated MCH degree. So I don't think that many universities are offering that. So you have to go for individual MS and MCH, or DNB broad specialty and DNB super specialty.
Regarding choosing DNB versus MCH, worried about pass percentage in DNB regarding different practical examinations, therefore feared to take the DNB.
It's nothing like that. Yes, on the face of it, it may look like it because in MCH you're on your home ground and your internal examiners are with you. So that gives you a little bit of a strength. Whereas in DNB, you go to a center, maybe totally different city also. But if your training is good and if your knowledge is good, passing the exam is not very difficult. So you should have, if you put enough effort into your training, you will breeze through the exams. So, I won't worry too much about that aspect.
What do you suggest for a surgeon? Academic path, clinical path?
Again, your passion, ideally both. And again, if you want to keep upgrading your skills and stay in the game, you should teach. I keep saying the best way to learn is to teach. So you will come to know your lacunae, and along with your students, you to learn. So don't take them separately. If you don't practice academics at all, you will become stagnant and you will sort of stay back in the game.
Any comments on the urology branch?
It's a good branch. What else can I say? So, and again, if you take urology, you can go into kidney transplantation, either exclusively or along with urology. Urology also has endourology. You have cystoscopy, nephroscopy, ureteroscopy. So many gadgets there. So.
And any comments on cardiothoracic surgery?
Again, same. I mean, you should have passion for it. I mean, during your, what I would suggest is for these sort of dilemmas, first decide whether you want to become a surgeon or not. So once you come into the surgical training, make sure you go for these rotations, whatever subjects that interest you, subspecialties that interests you. In the second year of your surgical training, you have to go to what is called peripheral postings. So again, depending on the university and the hospital that you are working, you may go to the peripherals after 6 months or sometimes go after 1 year. But it is compulsory that anything between 6 to 12 months, you have to go through peripheral postings. So during that time, you go to various subspecialties. So make sure that you go to the things that you have interest in. So if you are interested in urology, make sure you go to a urology posting during your peripheral postings. So if you do that, you will get a taste of what is there in urology. Then you will know for yourself whether that is for you or not. Please explain the importance of frozen biopsies in surgical oncology field and also in patients management and follow-up aspects. This is more of a super specialty question. So this is not for somebody who is actually wanting to get into the surgical training. Frozen sections are very important, but again, of late we are doing less and less frozen section biopsies because you want to know beforehand the diagnosis rather than do a frozen section and then decide on table what to do. Frozen section is more being done these days to look at the resection margins in cancer patients, whether the resection is complete or not, whether the margins are clear or not. In that aspect, the frozen sections are more useful. Manju Naik, yes, thank you, Manju. Good to see you. And
mobile phone, you need to mute, I think.
Okay, I'm getting the sound as well.
Yeah. Okay. So, what are the challenges to becoming a consultant in the UK? Yes, there will be challenges because first of all, you've been trained outside of the UK. And when someone goes to the UK, one has to first of all get adjusted to the system. So it is a cultural change as well. So when one goes, it takes time to get adjusted, and you're competing, mind you, with somebody who has trained there, and he's into the system already. Whereas somebody from India is going and trying to get into the system. It's not that they cannot get into the system, they can get into the system, but it is certainly, one has to adapt themselves. That is the first thing. One has to work very hard. We are quite poor in presentations at conferences, giving talks, presenting posters, and also publications. That is given, a lot of weight is given to that, in addition to, of course, communication skills, which will come anyway with the examination preparation. So I think if one has the fire in their belly that, yes, I want to go to the UK, I want to pursue training in the UK, it is possible to do. And with opening up of, the Indo-UK, I mean, United Kingdom is now desperate for doctors. They're desperate for nurses as well. And in all specialties, paramedical courses as well, they're opening up. So certainly there is future for those who intend to obtain their training there. But my advice would be to complete their basic surgical training here before going to the UK.
Here is a question of how to improve the hand skills, surgical skills. For laparoscopic surgery, you have the endo trainers, which you can use. But for regular surgical skills, you will get, again, as I mentioned in the talk, people look at small surgeries as menial. Suppose there is a sebaceous cyst. What I'm seeing in the present day surgical trainees is they don't want to do things like sebaceous cyst. But it gives you a very good exercise of doing the dissection, removing the sebaceous cyst and suturing it back together. So no surgery is small. Again, Professor Harold Ellis says, the big surgery is a series of small operations. So if you look at Whipple surgery, which is supposed to be the biggest in the abdominal surgeries, which contains 3 anastomosis and very radical dissection. If you split into small procedures, it is a series of small operations. Instead of putting 3 or 4 sutures for a sebaceous cyst, you will be putting something like 150, 200 sutures for a Whipple surgery. And you have to be meticulous in each of the sutures. So once you develop the hand-eye coordination and the basic surgical skills of tissue handling, dissection, and suturing it back together, the big surgeries automatically you will be able to do. So what I would suggest is, when you are in the surgical training, do concentrate on the small surgeries. I mean, people get a lot of lacerations and injuries in the casualty. And the surgical trainees, they tend to leave it to the casualty medical officers. They see that I'm too big to do these sort of suturing. So you can learn the tissue approximation techniques. You can do a nice plastic surgery job. So for you to develop plastic surgery skills, you have to wait until you have done the MS surgery and then go on to that. So you can just ask the plastic surgeon. And again, these days you have a lot of material available on the net, and you can see and you can practice those skills in the emergency. Do small surgeries, and if you're proficient with small surgeries, and if you have the enough theoretical knowledge, you will automatically be good at the big surgeries.
Any chances of robotic machine overtaking surgery rather than surgeon? Should aspirant surgeon be aware of this?
Yes, as of now, the robots are called master-slave configuration, meaning to say the robot cannot do anything on its own. So it basically mimics the surgeon's hand movements and it performs the surgery. So surgeon is 100% in control of the procedure. So robot doesn't have a mind of its own. But yes, the technological advances and artificial intelligence, all these things in 5, maybe 10 years time, that prospect is there, where a robo may be doing the surgery. But again, one of the slides I actually omitted. The presentation that I showed you is a little bit of a modified presentation from what I show to the surgical trainees in their first year of surgical training. So one of the slides is that, are surgeons going to be obsolete? So surgeons will never be obsolete. The type of surgery that we do will change. And some of the surgeries that we are doing present day may look barbaric to our future generations. That is why I keep telling, look at the history of surgery. What our forefathers did look barbaric to us. So in our own living memory, when I was a surgical trainee, we used to have at least 2 or 3 gastrojejunostomy and vagotomy surgeries every operating list. After the advent of proton pump inhibitors, the omeprazole and the rest of them, we hardly ever do any of these acid peptic disease surgeries. So the advent of these proton pump inhibitors is completely removed. Maybe once or twice a year we do. Likewise, if you get proper targeted therapy for malignancy, cancer surgeries may be gone into history. Our 100, 200 years down the line, our successors may look back and say that our forefathers used to do mutilating radical surgeries for cancer. Silly people. So it is what you have to do is think in the present and always be future ready. Surgeons will never be obsolete because there will be going to be injuries and new diseases and new areas where our help is needed. It is just that based on the advancement and the need, we have to adapt ourselves. If you don't adapt, yes, you will become obsolete. But if you adapt yourself, there is role for surgeons all the time.
Future after MS general surgery.
Which one is this?
What is the future of a trainee who finishes MS general surgery? After MS general surgery, what to do?
Surgery again, any of the, you can stay as a general surgeon. If you want to stay as a general surgeon, you have to work in the busy general surgery department, because unfortunately these days, nobody wants to be a general surgeon. People want, both patients and doctors alike, they want to have some specialty tag. So there's very few left behind for the general surgeon to do. But in the periphery and in the rural areas, there is still role for a overall general surgeon. So if you want to be a general surgeon, have good experience and try to work in a busy general surgical unit for about 2-3 years following your post-graduation, and then continue your career in general surgery. If you don't want general surgery, then you have a variety of specialties I have enumerated, and you can, depending on the availability and your passion, you can choose any of those specialties.
Surgery is looked upon as one of the most difficult, demotivating branch from the perspective of work-life balance. I don't agree. It's not the most difficult. So once, as I mentioned at the beginning, the big step is to take a decision to become a doctor. The next big step, or even bigger step, is to choose a career path. Once you choose a career path that you wish to become a surgeon, or anything else, in fact, any other specialty, I don't think anything should be difficult, because you need to have a fire in your belly to pursue that career path that you have chosen diligently, with focus, determination, and above all, hard work. With that, nothing will be difficult to achieve. And certainly once you have that fire in your belly, it will certainly not be demotivating. It should in fact inspire you and enthuse you to do more and more in that specialty to achieve whatever you have set out to do. And with regards to work-life balance, I think it's very important. Dr. Prasad also has mentioned it's very important to have, I don't know whether that's the right word, work-life balance. I think one has to strike a balance in life in terms of working for a profession that you honestly believe in, and for a career path that you have chosen, but at the same time not forgetting that life is not just about being a surgeon, or life is not just about being a doctor. There are so many other interests that one can develop, whether it is hobbies, whether it is meditation, whether it is, pursuing other aspects of life, which makes life interesting and complete. Many a times we come across, once you take up a profession, people are just from morning till evening, they know nothing else about life other than their profession. I think in that respect, one should, from the beginning, understand that practicing the art and science of surgery or being a doctor should be just one important aspect of life. One must always, try to understand that family is very important, trying to relax is very important, and trying to be grateful for what you are is very important on each and every day that we live. So that's the message that I would like to convey.
Well, I mean, there is a old saying, where there is a will, there is a way. So if you're passionate about something, you will find a way, and it doesn't demoralize you. And these days, we are seeing a lot of women in surgical training. A lot of females are coming to surgery. I think if you look at it grossly, there's about 70 to 30 ratio, female to male ratio in surgical trainees. So, and we have a number of lady surgeons who are very busy, and at the same time they are balancing their family life too. So it is how you do it, and it is not impossible. You can do it. One thing that we are sort of lacking in Indian scenario is group practice. In India, somehow we have this self-centered nature, and surgeons as a whole are egoistic. One of my friends once said, it is very difficult for a surgeon to decide who is the second best surgeon in the world, because the first best surgeon is always granted. It is himself or herself. So there is no doubt about it. The doubt only comes about the second best surgeon. So with that egocentric mind, people are not sort of forming groups. If you have a group and form a team, then your working environment becomes much easier. So you can share your work with your colleague, and you can take some rest, and when you are working, the colleague can take rest. So that is the way forward, and the next generation should seriously look into it. Even now there are some teams, but we should need more, and that should be the way forward.
Thank you, Prasad. So I think, we have spent about 50 minutes in this session, and I hope this session was useful to you. And we look forward to welcoming you back to DocTutorials once again soon. Thank you, and have a good weekend.
Yes, thank you, Raghu. And I thank DocTutorials and all the participants for their enthusiasm. And I hope we have inspired some of them or all of them to become future surgeons. And I wish all the very best to